exciting. All right, our objectives. First, we want to be able to state the function of the system. We want to acknowledge we want to have the knowledge to properly assess the musculoskeletal system. We want to understand homeostasis so that we can, therefore, then determine what the signs and symptoms of dysfunction are within the system. And we want to have a working knowledge of individuals suffering from sprains and strains, fracture, low back pain, and compartment syndrome, okay? And most of that we're going to get to tomorrow. Today we're just going to get a brief overview of the pathology of what's going on with this system, and we maybe make it into sprains and strains. All right, bone function, support. So it supports our body, right? If we didn't have bones, we'd just be like a little pile of goo, I guess. Protection of internal organs. So who can tell me some organs that are protected by bones? Brains, or lungs, heart, absolutely. Okay, and then it helps us with voluntary movement. Blood cell production. We're going to get into that in just a few minutes. And mineral storage. Who knows the type of minerals that are stored within the bone? Does anybody know? Calcium. All right, good job, guys. So, we are going to talk about the microscopic structure, and there's 3 types of bone cells: osteoblasts, osteocytes, and osteoclasts. Now, the way that I remember them, it may not make sense to you guys, but blast, I think of like a jackhammer, like whenever they're, doing like a sidewalk or something, they're breaking that up to build something new. So whenever I think of osteoblast, I think of breaking something up to build something new. So like the synthesized organic bone matrix and are the basic bone forming cells, okay? Osteoclasts, I think of collapsing, so that's again breaking those, so it's involved in bone remodeling, so breakdown of bone tissue. And then we have the osteocytes, which are your mature bone cells. Okay, this is our structure of our bones. We have the epiphysis, and that's up there at the top. I always forget which one is the... There we go, right here. Now, why would you think that epiphysis needs to be wide and thick like that? Does anybody know? Well, what does it do?
Stabilization.
It's stabilizing your muscles, right? Mm-hmm. So we need the stability of having that wide, and then it also helps us bear weight. It's there for a lot of reasons. So stabilization helps to bear weight. Then we have our diaphysis, which is the length of the bone. And it's the main shaft of the bone and provides structural support, and is composed of compact bone. It also helps us withstand force trauma, like jarring, anything like that. When you're jumping, it helps to absorb the shock from that. Okay. And then we have the metaphysis. I always say that wrong. And metaphysis? I don't know how you say it. Metaphysis, right? Does that sound good to you guys? Okay, sounds good to me. Okay, and it is right there. It conjoins the epiphysis and the metaphysis. It's kind of like right in the middle here. It doesn't really show it, but right there. Okay, and then have you guys heard of growth plates? Okay, that's your epithelial plate, which helps with, it's a cartilaginous area between the epiphysis and metaphysis. It actively produces bone to allow longitudinal growth in children. Injury to this area in a growing child can lead to a shortened extremity, can cause significant functional problems, and this area, as you're an adult, it begins to harden, and it turns into osteocytes, which are your mature bone cells, right? Okay. And then you have your periosteum, which is composed of connective tissue, and it covers the bone, and this is where your bone gets its nutrients. This is composed of all tiny little vessels there that penetrate the periosteum, and they provide nutrients to the bone. And then you have medullary, which is the marrow or the inner cavity. Let's see. I have a hard time seeing all the way over there. Like you can see it right there. It's where your marrow is. Does anybody know what different colors of marrow we have in our body?
Yellow and red.
Yellow and red. Did y'all just read that?
No.
No, you knew it? That's awesome. I didn't know that, so y'all are a step ahead of me. So yellow, what do you think consists of yellow marrow? Adipose tissue, absolutely. And what about red marrow?
Red blood cell.
Well, it's what breaks down and what builds that's how we, what's it called? It's how we form our bone. Hematopoiesis, there we go, our blood cells. So it's part of the hematopoiesis, okay? So the yellow marrow, it can be used to build build blood cells, but that's not its main function. Really, the red marrow is where we do that. And the red marrow is found in our skull, our ribs, our sternum, our pelvis, our vertebra, and our shoulder bones. All right, moving on. So what types of bones do we have in our body? Well, there's 204 of them. We have long bones, short bones, flat bones, and irregular bones. Can somebody give me an example of a long bone? Femur, absolutely. Short bone. Metatarsals, that's right. What about a flat bone? Skull, that's right. Okay, and irregular bones. Anybody know those? Your vertebra? Yeah. What about what's in your ear? Your ossicles in your ear? Those are irregular bones. Good job. Joints. This is a place where the end of two bones are in proximity and move in relation to each other. So we've got all these joints in our body. Joints are classified by the degree of movement that they allow. And the most common is your synovial joint. And here we have pictures of different joints up here on the top here. This is your skull. So that's classified as an immovable joint or a synarthrotic. These words are hard for me to say. So immovable is what you want to think of. And once those soft spots fuse in your head, whenever you're 24 months is whenever they finally fuse, or 48. Do y'all remember that? 18 months. So it should be closed by 24, right? All the way. So then at that point, that is no longer movable. So it's going to be an immovable joint. And then right here in your vertebra. Now, what is this classified at? Would this be a movable or an immovable joint? Movable, absolutely, because it helps us to bend over. We wouldn't be able to bend if it was immovable, right? Now, where is this at? Do you know where that's located?
It's in your pelvis.
In your pelvic. Yeah, that's your pubis bone. So that is an immovable joint. All right. And then we have the greater trochanter. That's movable, obviously. And we have our femur, obviously movable. All right. So you guys got that down. So different types of joints. We have the hinge joint, which is your foot. So you can flex and extend that joint. You can do that? Everybody do that? Yeah. Good job. Ball and socket, that's your shoulder. And it provides for extension. So you can extend that shoulder. You can flex it. You can abduct it. What does abduct mean? Bring.
You say A, B.
Add. Add is bringing in. Ab is away. Okay. So it provides for adduction and abduction and circumduction. So you can move your arm in a circle. I was in the military and they used to make us sit out there like this forever. We just sit there. And yeah, that doesn't feel too good when you do it for a while. All right, pivot. This is for rotation. So this is your bones here in your arm that provide for rotation. Condyloid, it's right here in your wrist. And you can flex and extend your wrist. You can abduct it or adduct it, and you can circumflex it also. Saddle, that's your thumb. And your thumb has flexion, extension, abduction, adduction, circumduction, and thumb and finger opposition. What is that? So, someone's phone is going off up here. You want to take that call for you? And you have a gliding joint, and that's where one surface moves over another surface. And that kind of happens in your wrist again. So that's pretty self-explanatory. You guys got that? Yep. Okay. So what is cartilage? It is a rigid connective tissue in synovial joints that serves as a support for soft tissue and provides the articular surface for joint movement. So it's avascular. So that means there isn't any vascular system involved in your cartilage, right? So would you think that whenever you tear your cartilage, would you think that you would have a short healing time or a long healing time if it's avascular? Exactly. Good job. And hyaline cartilage is your most common. And it is located in your trachea, in your bronchi, your nose, your epiphyseal plate, we talked about that earlier, and your articular surfaces of the bones. Then you have your elastic cartilage, which is in your ear, and your epiglottitis, and your larynx. And then you have your fibrous cartilage, and that is going to be your shock absorber. So anything that is going to withstand any kind of shock. So your vertebral discs, your protective cushion between the bones of the shoulder, your pelvic girdle, your knees, those are all going to be fibrous cartilage. That's where that's going to be, okay? Muscle. So we have different kinds of muscle. We have cardiac, which is striated involuntary. What does involuntary mean?
Don't think about it.
Right. So we don't have to sit here and think about our heart beating and make it beat. Can you imagine that wouldn't be fun. Smooth is non-striated and involuntary. Where is smooth muscle located?
Your uterus.
Uterus, absolutely. Where else?
Your respiratory.
Respiratory, your airway. Good job. Anywhere else you can think of?
Is it bladder?
Bladder, your GI tract. Internal organs. Yeah, just all over the place, right? It's your GI tract, your uterus, your bladder, all those. And those are controlled, those muscles are controlled by neuronal and hormonal influences. So we talked about hormones and how it can contract, we talked about hormones with the endocrine system, and how whenever you have hyperthyroidism, you have diarrhea a lot, and you remember that. So it helps those muscles, that hormone is affecting those muscles and making that bowel system work, even increasing peristalsis. Okay? And then we have our skeletal muscles, which are striated and involuntary. And they require, what type of innervation do you think it requires? Well, I just told you. it requires nerves, right? You have to have nerves that moving and operating that skeletal muscle. So contraction, it allows for posture maintenance, body movement, and your facial expressions. You have isometric contractions and isotonic contractions. And isometric, you increase the tension, but there's no movement. And your isotonic, you shorten the muscle and it produces movement. So those work together to produce movement. All right, slow fibers. And you guys have talked about this before, your slow twitch muscles and your fast twitch. Y'all talked about that? Slow twitch is to help you with, maintaining or prolonging muscle activity in marathon running, nursing school. You have to have slow twitch muscles, right? It's not a fast twitch kind of thing. Fast twitch, it's going to be producing rapid muscle contraction. So you could be jumping, blinking your eyes, sprinting, biking, anything that you're going to be doing in like short bursts of activity. That's going to be your fast twitch. And then, of course, your marathon running is your slow twitch. Ligaments and tendons. They're composed of dense, fibrous connective tissue that contains bundles of closely packed collagen fibers arranged in the same place for additional strength. Okay, so what does that mean? So, our tendons, basically they're there to provide stability and to maintain function of that muscle, okay? So tendons connect muscle to the bone and ligaments connect bone to bone. Once again, do you think that these tendons and ligaments are going to be easy to heal? No, it's going to take lots of time. And if anybody's had a torn ligament or torn tendon, then you can attest to the fact that it's a long, drawn-out process of that ligament and tendon healing. It takes a long time. And then unless you have the proper physical therapy, then it probably isn't going to heal correctly, right? So then you're going to have increased pain. It could be chronic. So poor blood supply to both of those, so slow repair to the tissue. Your fascia is your layers of connective tissue with intermeshed fibers that can withstand limited stretching. Okay. Do you guys see what the fascia is over here, this picture? So you got your muscle, then you've got your filaments, your muscle fibers in here, and then you've got your fascia. So it bundles those fibers up, it gives them stability, and it surrounds the muscle bundles and the nerves and the blood vessels. That's the deep fascia. Superficial just lies directly underneath your skin. It allows muscles to act independently, to glide over each other, and it provides strength to that muscle. Bursa. Now these are small sacs of connective tissue that lined with synovial fluid. Well, it's a small sac of synovial fluid that helps with those bony prominences or joints. So you've got synovial fluid or bursa in your knee, right? It's in between your patella and your skin. Let's see, where else do you have it? You have it in your elbow. Can you guys think of anywhere else? I think your hip. Yeah, your hip. Absolutely. So you have it in your hip. So that just helps keep that joint lubricated and moving well. So when you have problems with your bursa, what is that called? Bursitis, right? So that's infection inside of that bursa right there. So would that help the joint move freely? And no, it's going to cause pain with movement with that joint. And so it's inflammation of the bursa sac, and it can be acute or it can be chronic. All right, so now we're going to talk about our older population. And this is an area that you really want to assess effectively for our older population, because there's so many ways that this can impact their lives, right? With having decreased strength, loss of muscle strength, loss of motor neurons, their tendons and ligaments aren't as flexible. So what happens whenever you have stiff ligaments and tendons? Would your gait just be normal? Would you maybe have some trouble with your gait, ataxic maybe? Maybe it's just really hard to walk, so you're going to be really stiff. You know how when you get up, I do it now. When you get up out of the chair, you're just like, oh, my joints are hurting. It kind of takes a minute to move around and get them working. So absolutely, when you get older, it becomes harder, and those joints are less, there's not enough fluid in those joints to keep them lubricated. So they just get less flexible, harder, stiffer, rigid. So it's going to be hard for them to walk around. Loss of strength. About 30% of muscle mass is lost by the age 70. So, and then does anybody know what proprioception is? Yeah, is that how you say it?
Knowing where your body is.
Exactly, yeah. And it's, you want to say it louder so they can hear it? Or you want to say it louder? One of you guys.
It's like knowing where your body parts are.
Yeah, knowing where your body parts are. So when you get older, you don't perceive things the way that you used to. So you might run into something, or you might miss a step. A lot of our older population will do that. They'll miss a step, and they'll misjudge how far down it is, and then that's going to lead to falls. And I was talking to Miss Jordan today. I don't know if you guys know her. She's a clinical instructor, and she also is a gerontological nurse practitioner. And she said that at age 70, if you break your hip, well, no, not at age 70. She said if you break your hip, there's a 70% chance that you are going to possibly die within the next year. And why do you guys think that would be? Complications. Yeah, absolutely. Whenever you break a hip, what happens? What are the steps that we put that patient through?
You're immobile.
Immobile. They're immobile. Absolutely. Are they in their home with their people, or are they're in the hospital, they're in rehab, they're in nursing homes if they don't have family members that can take care of them properly. So now we've got an elderly patient that has been exposed to infection because they may have to have gone in and fixed that fracture, right? So now they've had surgery, they've been exposed to infection, they are out of their normal living environment, they're no longer able to take care of themselves, they're ADLs. So do you think that maybe they could be struggling with some depression? Mm-hmm. Absolutely. These people are maybe used to taking care of themselves, used to doing everything for themselves, and now they're having to fully rely on somebody to take care of them, bathe them, all those things, and they're out of their environment because they may have to go to rehab, and that's inpatient sometimes. So it's no wonder that there's a 70% chance that it can lead to death, because with all those exposure to infection, depression, all those things, it could just be easy for them to just give up and not really want to be here anymore, you know? So we want to protect our older population. How can we do that within the hospital? I know you guys have been doing your clinicals. Of course, you guys see your fall risk signs. What all do they have in place for us as nurses? What can we do to prevent falls?
Bed alarms.
The socks,
Bed rails.
bed rails,
Bed alarm.
bed alarms,
The low position.
low position, absolutely.
Rooms, clutter-free.
Well-lit room, that's great.
Some hospitals have the camera systems. that-
Yeah.
The virtual, with the virtual bed rail.
Yes, yeah, those are neat. But absolutely, we want to do everything that we can to prevent falls. I was in the VA. I was having problems with that intracranial pressure stuff that I told you guys about not too long ago. And I had a patient that was, well, it wasn't my patient. I was in the hospital. But there was a guy right next door to me, and he was kind of a belligerent patient. You know, you could tell nobody wanted to come down to the end of the hall to mess with him because he was hollering, he was screaming, he was acting up. He kept getting out of the bed, and for some reason the nurse she wasn't putting the bed alarm on. I don't know why. So neglect on her part. So she is down here messing with him, says, "Don't you dare get it back out of bed," blah, blah, blah. He's trying to take his clothes off. She walks up the hall, and I'm sitting in there in the bed, and I hear him get up, and I'm like, oh, crap. So I'm thinking, please don't get out of the bed. Sure enough, he walks into the bathroom, slips, and breaks his hip. Open fracture to his hip.
Oh.
I mean, his bone is sticking out. Everybody's panicking. And, I mean, there were some things that could definitely have been prevented there. You know, he was attached to all kinds of stuff, and his gown wasn't tied up. He didn't have the bed alarm on. There's lots of ways that could have been prevented, and I don't know what happened to him, but I know that he was, because this was in Murfreesboro, so he was sent up here to the VA here in Nashville, and I'm sure had surgery. But it didn't sound like he was in very good health to begin with, and then now he's got an open fracture to his hip. So really take care of your patients, you know. And the best part of, if they're coherent and you can talk to them, explain to them the importance of, please call me. I'm not doing this to get on your nerves. I'm not trying to make you, you know, feel like you're confined to this space, but I'm really trying to protect you. I want you to be healthy. I don't want you to, you know, sustain a fall while you're here. So please call me, okay? Just talk to your patients. Let them know that you care about them. Let them know that you're concerned about their health and well-being, because you are, or you wouldn't be a nurse, right? So just take care of them. Okay, and then we're going to have problems with bone density. And we're going to talk about a DEXA scan where they check for the density of the bones, things like that. Loss of motor neurons, so maybe they're just not able to react. You know, that could have a lot to do with those falls and people not being able to react the way that a normal, you know, well, not normal, but maybe a healthier, younger person would be able to react to a fall. Maybe they would move and kind of turn to the side. An older individual doesn't have that ability to think like that and respond as quickly as a younger one. Okay, so we're going to go into the assessment portion. So we talked a lot about this, and what do we start with when we're doing an assessment? We'll start with that. Subjective data, absolutely. So you're going to walk in to your client. Maybe you're in the ICU and you can't talk to them. They're intubated, and they're not coherent, so you can't talk to them. So you want to get that chart, look through, doing a proper assessment on, you know, what is this patient's mobility when they're not intubated. So because what happens when they are extubated and you don't know, and now they're able to get out of that bed, and you've got the bed sitting up way high, and the lights out, and you know, stuff, you know, blocking their way. Okay, so you have to be thinking about these things for your patients. So common symptoms are obviously pain. I know that every one of us in here has probably had some kind of joint pain, back pain, something like that. Knee pain if you're an athlete, or even if you're not. Weakness, and could this be unilateral, bilateral, any kind, right? Any kind of weakness. Deformity. We're going to talk a little bit about amputations tomorrow. So if you know that they have had an amputation and maybe they have a prosthetic device, you want to make sure that you are aware of that as a nurse and can help them with that, know a little bit about it. Limitation of movement, stiffness, and joint crepitation. Does anybody know what that is? Yeah. When I walk up the stairs, it's like crackles. Yeah, it's gravel. It's awful. Bad thing. So joint crepitation. So this is where we're going to start with our subjective data. We're going to take that past health history. What would we want to be looking for in that health history? Anybody know? What diseases, infections, things like that can osteoporosis, okay. What else? Arthritis. Oh, good job. What about anything that we had to do with the endocrine system? Do you remember anything? We didn't talk a whole lot about it, but there was one gland that had to do with calcium. What gland was that? Parathyroid. Good job. So you want to know about any kind of parathyroid problems. Rickets. I didn't know this, but breastfed babies don't receive as much vitamin D as, bottle-fed babies. So if you have a mom that's coming in and she's nursing, then you might want to, say that the baby needs to have some vitamin D, like polybasol, one of those over-the-counter, like drops. I didn't know this, but my pediatrician was telling me with my youngest one that there's been she had a couple of cases of rickets there at the office because of breastfed babies that didn't have enough vitamin D. So we want to know about vitamin D deficiency. What else do we want to know about? What else was in the endocrine system that would have something to do with our muscular system? Hmm? Diabetes, absolutely. Absolutely. These are probably, you definitely want to be looking at your diabetic patients, right? Okay. Certain medications that you want to be aware of that can cause problems. Corticosteroids can cause avascular necrosis, which is where blood supply is cut off and it usually happens in the hip. Maybe there's some kind of herniation or something with the nerves that's cut off this nerve supply to this hip, so this hip bone is going to start necrosing, start dying. You can see that on x-ray. So avascular necrosis is corticosteroids. Potassium depleting diuretics. What would that do to your musculoskeletal system? When we decrease the potassium, does anybody know? Cramps, right. Tell them to eat a banana? Yeah. Your patients are going to get cramps. All right. Let's see if there's any anti-seizure medications can cause osteomalacia. So just some things that you want to think about when you're doing that, you're taking that subjective data. All right, objective data. So this is when we're going to physically assess this patient, right? We're going to inspect, palpate. We're going to take measurements. I've never done that as far as, but maybe if you work for an orthopedic surgeon or something like that, I'm sure you'll be taking measurements. And absolutely with scoliosis, you want to take a measurement. So I used to work for a benefits management program. It's like your insurance companies, they kind of say whether or not you can have testing. And we would have people call in with scoliosis, and it had to be a certain degree of scoliosis before we would approve any kind of testing, MRI or anything like that. It's just the way that the system works now. But now if you have a 45 degree curve there, then you could start having problems with your cardiovascular system, your lungs, things like that. So it can be really dangerous. All right, so we're also going to do neurovascular assessment as part of this as well. Has anybody performed a neurovascular assessment before? Yeah, you have? Awesome. Okay. Well, I was going to demonstrate. Let's see how much time we have. Are we good? Okay, it's 4 o'clock. All right. So, somebody want to come up here and be my guinea pig?
Me? I do it.
All right. Come on. Come on in. Come on down. Yes.
Okay.
Well, actually, they're going to. I'm going to walk you guys through it.
Okay.
Okay, so for a neurovascular assessment, what are the 5 things, the 5 P's? Y'all remember that from when you talked about it before? Okay, you're gonna assess for pain, pulses,
Tingling.
paresthesia.
Yes.
Yeah, I know, I did that. Okay, so we got 3 of them. Paralysis and pallor. Good job, guys. Okay, so how are we gonna assess for pain? Ask. Are you in pain? No, good, I'm glad. Now, what if she can't say whether or not she's in pain? What can we look at? Response. Facial expression. Okay, what about if she's completely intubated and we don't know if she's in pain or not? Like, what can we look at diagnostically? Vital signs, absolutely. So what would be present if it was a patient that's experiencing pain?
Increased heart rate.
Increased heart rate.
Blood pressure.
Blood pressure is increased. Good job. So we've assessed pain thoroughly. Did we leave anything out? No? Okay.
We check, she's like, if she can feel pain or like certain extremities.
You could. You could. You could pinch her.
She's
Absolutely. The needle prick kind of thing. Yeah, you could do that. Absolutely. Now, what would be a reason that we would do this neurovascular check?
Make sure that they still have sensation.
Yeah.
See how alert they
Stroke.
are.
Okay. What else? What else could a patient be coming in? I know that we've talked about this in the DKA. Absolutely, nerve damage. Because what takes place in diabetic patients? Neuropathy. Good job. What about increased intracranial pressure? Would we need to check somebody with neurovascular assessment? Absolutely. Let me think of anything else. I can't think of anything. Spinal cord injury? Absolutely.
Just patients that have fallen, sometimes the elderly, they're just trying to roll out
Right.
medication, if you give them too much medication.
Yeah, it's perfect. Did you guys hear that?
No.
Elderly population, you want to just, if they've experienced falls in the past, you want to just do a neurovascular check, just to assess them as far as their medication. Maybe they're receiving too much of something that's inhibiting them. Okay, so we've assessed pain. Now where are we going to start? Pulses, we could do pulses. What pulses are you going to check? Radial, you can check the radial pulse. Pedal pulse, peripheral pulse. Now what about femoral? If you got a patient that's in the bed, like, and he's intubated, you could definitely check that. You want to check your pedal pulses. We said that. What about, what's the one behind here? What's that? Popliteal. There you go. Popliteal is behind here, and then you got your dorsal. There, sure. So we want to check all of those pulses. And now, what if we were checking the femoral pulse and it was good? We moved down, we checked the popliteal, and it wasn't.
There's
There's
something.
There's a block in there.
Some kind of something going on. Then you would want to assess for what, maybe redness, inflammation. What could we have possibly? DVT. Absolutely. Something that's, some kind of claudication that's affecting the blood flow. So, which that's not musculoskeletal, but still, it's a good thing to know, right? This is putting it all together where you kind of have to you're at the point now where you're going to have all this information up here, because it won't be long when you'll be walking into a patient's room and you'll be required to do this stuff without a book or without, your little PowerPoints or anything like that. So just start, you've got all the information there, just start processing through it, because you guys have got it. You're doing really great. Okay, so we've assessed her pulses, pedal pulses, and her peripheral pulses, her radial pulses. Oh, we've done all that. Now what are we going to do? Paresthesia. Now how do you check for paresthesia?
You can check if the dull or sharp something is.
Something that's dull or sharp. Yeah.
I can tell you if it's dull or sharp.
I should have brought it. What about a cotton swab? What could you do with that?
Just kind of rub it against.
Yeah.
Poke it.
Rub it. And if you don't have anything, you could just say, does this feel the same on both sides? Can you feel that? Okay. That's going to check too. So that's paresthesia, right? What else? Is there anything else we can do to check for that? We could ask again, are you having any numbness and tingling in your extremities? Okay. And what if they say, well, of course I am, I'm diabetic. I always have numbness and tingling. Then what are you going to talk about? Any changes? Absolutely. You're gonna maybe ask them if they're on any medication for that, Neurontin, gabapentin, one of those. I mean, well, this is the same thing. But, so just you see how all this kind of builds on itself? Once you have all this knowledge, you just kind of go with it. Okay, so we checked for paresthesia. Now, so we've got pain. What else? Pulses, paresthesia, pallor. So we're gonna look at her. Does she look like she's pale or any discoloration? No? Looks good, right? Okay. Now, what was the last one? Paralysis. So what do we do to check for paralysis? Strength testing. And how do you determine strength testing? Like, what kind of scale do you use? Do you
1 to
use
5.
0 to 5. Okay, 0 being least, and then 5 being normal. Okay. So how have you guys done it in the hospitals? Have y'all been doing your assessment and checking for muscle strength? Okay, so you go up to your patient and you say, squeeze my hand as hard as you can? Okay. All right. Yeah, do you do that?
Yeah.
Okay, then you could say, make a muscle, do this right here. Okay, now I'm going to pull, just don't let me pull back, okay? So then you got to pull.
Oh, what do you mean?
How do you explain that? How would you explain it?
Don't let me pull you.
Don't let me pull your arms down?
So pull.
Yeah, don't let me
Yes,
see
don't let me pull your arms down. Good job. Okay, now don't let me push your arms down. Okay. So you want to check that. How would you check it in the lower extremities?
Push against
Same way?
Fine.
You can push against your feet.
Push against your feet and pull back. And you can do that really great in the bed, right? You can do that, go down to the bed, work that out. All right, so we're checking for, so I think we've got them all, haven't we?
Yes.
All right, so what would we say about her? Would we say muscle strength is 5?
Yes.
Okay, everything looks good, right? Within normal limits. Good job.
Thanks.
Yes, ma'am.
Okay, as far as the scale for muscle strength, I get the concept, but like, I mean, when it gets between like 4, 3, 2, 1, like how do you kind of differentiate?
As long as I've done it, I've never had like a 3 or a 3 or 4. Like, you either have it or you don't, kind of thing. Now you can, now if it feels like there's strength there, but it's a little weak, like you could put a 2. Whenever I had that intracranial pressure stuff going on, I lost ability to raise my arm on this side. But then when it came back, it was very weak, and it still is, like to this day. This side's a lot weaker than my right side. And so, you know, you would say, you just kind of want to know what the person's baseline is too, because you can't really say you've got an elderly patient in there and they barely squeeze. You don't want to put he's a 2, whenever really it's just he's an older patient who's not as strong. You know, you kind of want to use your clinical judgment there.
How do you know it's still weak, but what kind of, like, how can you tell that it's still weak to this day on that side?
Just I have a neuro check every time I go to the doctor.
Oh.
She does it every time. She goes through the whole big thing. Now, what else would we want to check when we're doing a neuromuscular exam?
Pupils?
Pupils, well, coordination, hand-eye coordination. What about gait? Would we want to check their gait? Yeah, and how would you want them to walk?
In a straight line.
In a straight line? Heel to toe, you could do that. You could just say, just walk normal. What could you tell is going on with somebody just by their gait? You could tell some dysfunction, right? What if they're having a taxic gait? What does that mean?
No, they can't.
Can't emulate, right?
Yeah.
They're not able to. What if they have
Shuffle.
Yeah, shuffle gait. What could that be? Could be Parkinson's, right? What about, what did they call it? A stepped gait? What's that significant for? You ever seen anybody with foot drop? When they're picking that foot up? Where do you see that a lot? Stroke patients? Somebody said it. Your stroke patient? Spinal cord injury, right. So, just things to look for. Alrighty. So I think we went over the muscle testing. So 0 is no detection of muscular contraction, and 5 is active movement against full resistance without evident fatigue or normal muscle strength. So that's there for you guys. Diagnostic studies. Oh, I was going to tell you a story. Let me go back here. Okay, so, make sure I'm at the right spot. Yes, okay. Now, an important part of whenever we're assessing somebody is their range of motion, right? We want to assess their range of motion, if they have full range of motion or if there's any kind of deficiencies in their range of motion. And now, if you're working in the ICU and you have a patient that's intubated and in a medical induced coma or something like that, what are you going to want to be doing with that patient? Does anybody know? Passive range of motion, absolutely. Because when they're in that bed, what's happening to those muscles? They're just atrophying, absolutely. So we really want to focus on that, and we can do something. We can do something to prevent it, so why don't we, right? But the story, whenever I first got out of nursing school, I worked at University of Colorado Hospital, and she was like my second patient, and she was I think she was like 24-year-old pharmacist that worked up on the cancer floor. And one day she was working and she felt a knot on the back of her neck. And so she had one of the docs take a look at it. And they said, well, it feels a little suspicious. Why don't you go down and have some imaging done? Turns out she had ALL. Does anybody know what that is? Acute lymphoblastic leukemia. So, and she was young, 20, but usually it happens in kids, so it was a little odd. So here she was like 24, I think. She had just gotten married. She'd been married like 6 months, I think, and now she's got ALL. And by the time that I got her, it was in the medical intensive care, and she also had aspergillus. Does anybody know what aspergillus is? Well, we're exposed to it all the time. It's probably up here in these tiles right now. But because she was immunocompromised, it infected her, and it made lesions on her brain. It put all kinds of stuff in her lungs, so she was coughing up like green stuff. Anyways, she ended up dying. Very sad. It was like my first patient that I lost. But her husband, who had only been with her for about 6 months, was in there doing passive range of motion with her. I was like, that's the sweetest thing I've ever seen. But, and somebody had to have taught him that because he wasn't a nurse or anything like that. So that's something that you can think about. Because when you have somebody that's in such, a bad state of health, you feel really hopeless as a parent or as a mother, a sister, brother. What's something that you could instruct that patient in or that person in to help that patient? And that would be a great thing. Teach them how to do passive range of motion because he was in there and he was doing it with her. MRI
for the class, and I should have your grades posted. I'm gonna try to have it by this afternoon. It's pretty good, so hopefully you guys can get some peace of mind. Okay. All right.
Thanks, guys.
What time is the test? I'm not sure.
It's at 8.
Should have said.